Please join me in welcoming Dr. Ann Neumeyer. She's the medical director of the Laurie Center for Autism at Massachusetts General Hospital and associate professor of neurology at Harvard Medical School. Dr. Neumeyer is a member of the PMSF Medical Advisory Committee and the PMS Neuropsychiatric Consultation Group. She has dedicated her career to improving the lives of patients with autism spectrum disorder and related conditions. Her research and advocacy work has made significant impacts on clinical services and patient care. So please join me in welcoming Dr. Ann Neumeyer.
Well, thank you for having me here. I learned so much by coming to this meeting, and so I'm grateful to all of you. And I also want to say it's very hard for me to give this talk following Dr. Kohlenberg's presentation. Because Tacey did such a wonderful, wonderful job. So anyway, I'll do my best. I don't have any conflicts. So I'm going to move here. So I'm going to talk about evaluation of a child with PMS and behavior regression. What are the behaviors and what's regression? What do we know about behaviors in PMS? And then talk about expression of pain in minimally verbal children and adults, some of the medical issues that interplay with all of this, and a little bit on psychiatric. So what is a regression? There are a lot of different ideas about what a regression is, but we typically think like a 3-month duration where you lose some of your milestones. So it might be language or motor or self-help skills, social engagement, ability to play, or activities of daily living. And you can have change in behaviors like more self-stimulatory or repetitive behaviors, more repetitive behaviors, or echolalia and aggressions. So if you were at Tacey's talk, you would have seen this in her videos because they were absolutely fabulous. Okay, in PMS, at least half of parents in the old online survey that we did, they reported a regression, and in the literature also we see that at least about a half of parents report a regression in PMS. We see frequent regression in children under the age of 3, and there's also many children who have a regression around the age of 6. I guess I had that twice. But then we also see later regressions, and those are very tricky to understand. What is causing the regression? Is it a neuropsychiatric condition, or is it something else? And what is provoking the regression? Could it be an infection or illness, seizures or epilepsy, environmental stresses, and mental illness, including catatonia or bipolar disease or other depression? So from the registry data, you as parents reported that 59% of children with a regression lost their motor skills, 53% lost self-help skills, 14% lost language, 33 or a third percent lost their social intent, more purposeful, 29% lost purposeful hand movements, and play skills were lost more in girls than boys. So behavior changes, as you all know, are really, really impactful. And from the repository, we learned that wandering, aggression, screaming, flopping on the ground, inappropriate laughing, eating non-food items, excessive cleaning, withdrawal, jumping, flapping, and self-injurious behaviors. They're all very impactful to the family, to the school, to our quality of life. So, what causes these changes? And sometimes they're associated with medical illness. Less often they're associated with seizures. They're associated with neuropsychiatric conditions, and sometimes we just don't know. So what I'm going to do is talk about the comorbidities or the associated conditions that we see that can cause regression or behavior changes. And I will always say that you can have a behavior change that starts as a medical condition and then is maintained by behavior. So I'm just going to give you a quick example. Child had an earache, started banging his head. So the school got very upset, immediately pulled the child out of class, called the mother. They went down to the nurse's office, what's going on? And it took a couple days, and finally they figured it out that there was an ear infection and treated it. Well, that child also learned that by banging his head, it was a pretty effective way of getting out of demands. So the behavior started as real pain, but then it was reinforced by other things. So why I'm telling you this is that it's really, really hard to figure out often what is causing a behavior and what is driving it to continue. And so I often really rely on the help of a good ABA therapist who will do something called a functional behavioral analysis, or an FBA, and that's essentially watching the child and trying to figure out what causes the behavior and what drives it and what supports it so that it continues. Okay, so we're going to start with pain. It's really hard to tell for many nonverbal children, and also children who have good language, whether they're in pain. So in a survey of parents, about a third of them noted that their child responded to pain by crying. They don't tell you at all. Or parents might recognize a particular phrase that the child uses when they're in pain. 8 respondents specified that they knew their child has a high tolerance for pain, and we do know that there's more hyporeactivity or less ability to feel things in children with PMS as compared to autism. And so that's really important, is that the kids might experience pain, but they don't react or tell you. And there have been studies even where they draw blood, and in kids with autism, for example, and the kids that don't react are still having an elevated heart rate and an elevated blood pressure, so they're feeling the pain, but they're just not reacting to it. And so that's important to remember. So pain looks different in every child, so we have to be detectives. And nonverbal children will often express pain nonverbally. And of course, 75% of children with PMS have impaired communication. So sometimes all we see is that the child looks like more autistic. Their behaviors get worse, and it can be because they're in pain. So verbally, we hear that children will cry or scream. They have verbal tics. Throat clearing or swallowing frequently can be a sign of pain. If a kid has reflux, they might just be swallowing a lot or clearing their throat. Echolalia or scripted speech we talked about, talking about body parts or doctors or the dentist, can be a sign that they have pain. And I have had many parents tell me stories about how their child started talking about the dentist, and then they realized, oh, there's an infection in their mouth. So moaning, sobbing, crying, and aggressive vocalizations can also be pain. So especially for older children who are not living with you, when the group home calls and says, your child's being very aggressive, it's very important that you remind them also that this could be a sign that there's something wrong and that your child might have pain. Body movements, facial expressions, dystonia, so abnormal tone, like tensing even can be a sign that you have pain. Mouthing objects, when normally you don't mouth objects, so it's all changes in behavior. Changes in walking. I've had kids who've broken toes and just started walking with a limp, and it was because they had pain. Posture changes, tics, and dyskinesias, or changes in your tone or twisting, can also be a sign of pain, and I'll show you some examples later. My little thing isn't working very well. There. So behavior changes, such as, I'll just tell you. Irritability, changes in sleep, non-compliance, and self-injurious behaviors also are signs of pain. Oh, and appetite can be another sign of pain. When I'm in pain, I don't eat. Next slide, please. So I'm giving a talk on sleep at 4 or 4:30, so I'm not going to say a whole lot, but sleep is a big problem for many parents, especially as for some adults, it can be a real big problem. Children with PMS are really hard to do sleep studies with because you got to wear the leads all over your body and they don't feel good and everyone rips them off. So it's really hard to study. But if you are not sleeping well, aside from the fact that no one in the family then sleeps well, it can be really disruptive in school, and people who don't sleep well are not as healthy. And the problems with sleep are falling to sleep, staying asleep, and waking up early. Oop, I think I went too far. So, what causes sleep problems? Core deficits in behavior, anxiety, and routine, maybe low melatonin levels, pain, GI illness, constipation, reflux. Children can have obstructive sleep apnea, like their tonsils get too big and they just block you when your body relaxes, then your throat relaxes and it makes it hard to breathe. Low iron, so if your child is not eating a regular diet and you get low in iron, then you can have restless leg syndrome. So that's a nice, easy one to fix. And then there are the typical sleep disorders that we see that I'm not going to talk a lot about here, but when somebody's not sleeping, again, always look for an underlying cause. And when we have kids with bad behaviors and bad sleep, then I first try to work on the sleep because I know I'm pretty cranky if I don't sleep. And so why would anyone, we all are if we're not sleeping well. So treat that first before you treat the crankiness. So seizures, and especially nocturnal seizures, can cause changes in behavior. And if you're having seizures, that can make you look a little more autistic and change your behaviors. And children with seizures also have worse motor skills, attention. And again, they're common in PMS. So there's an ongoing talk in GI issues, so I'm surprised so many of you are here because that's such a problem in children with PMS. How much do GI issues negatively cause belly pain? So more than half of The parents surveyed said yes, it does. And I think GI issues really impact many children because of poor motility, so you have a higher risk of constipation. 40% of constipation, 85% of children have demonstrated pica or eating non-food objects. 42 have reflux, gastroesophageal reflux disease. And in this study, only 24% were toilet trained. So we also see a lot of nutritional disorders because of not eating properly. Vitamin C, vitamin D deficiency, poor protein intake, and I mentioned also iron intake, and for kids who aren't moving a lot or are on some of the antipsychotic medications, especially when they're young, you can get a lot of increased weight also, and obesity. So this, you can just start it. This is a behavior in a young woman that nobody could figure out, and it kind of looks like a seizure. It's a repetitive behavior, and it also involves kind of what we call tonic posturing, where your body gets a little stiff, but really unusual postures. And as you can see, it's a pretty old video. But I think it's really important because this is not due to a neurological cause. It's due to reflux. And little babies get reflux, and they twist their head and they arch their backs, and we call it Sandifer syndrome. And a smart gastroenterologist put a pH probe down and saw that every time she had these behaviors, the pH was dropping in her esophagus. And she was doing this all because she was in pain. This is an example of how behaviors can really tell us that you're in pain. And once she was treated, it all got better. Immediately. It was remarkable. So, drug reactions. There's so many. And every child, even if you have a friend who has a child with PMS and they responded well to a certain medication, it doesn't mean that your child will. And everyone seems to react very differently to medicines. So I have had I had one child who was on what I thought was a very harmless allergy medicine, and she had such behaviors and even broke her nose from banging her head, until finally the smart mother just stopped giving the allergy medicine, and everything went away. And it's still painful for me because I didn't think about it, the mother did. So we'll talk about that later, but every new medicine, always start only one medicine at a time, because it can be so confusing at trying to understand what is going on. And when you do see a new behavior, just videotape it, because that might be a good source of information. It's kind of like the sound that you get in your car and then you bring it to the mechanic and the sound is gone. So, because we may not see it in the office and we may not see it if we're doing a video visit, so save those videos. So endocrine conditions, hypothyroidism, of course, is really important because there's a high risk of hypothyroidism, and that can cause behavior changes too. It can affect your sleep. So certainly think about that and remind your doctor that this can be a problem in kids with PMS. And then the other PMS, for all the girls who are going through puberty, we see changes in behavior. We see sometimes seizures that occur just because of hormonal fluctuations. And so oftentimes using a birth control pill, whether it's estrogen or progesterone based, but sometimes you have to try a couple different ones, can be very helpful in regulating behavior. And for girls and boys, adolescence is bad no matter who you are. So, and then urinary tract infections, always just remind everyone to think of that. So the psychiatric comorbidities. I think Tazy really talked about these well, so I won't spend a lot of time on them. But if your child is typically not showing a behavior and you suddenly get a new behavior, whether it's hyperactivity or impulsivity or irritability or aggression or repetitive behaviors or a change in their mood or anxiety, think about whether there could be something underlying going on before, and remind your care providers or medical providers that it could be something other than just pure psychiatric, but it could be pain or medically related. So these are 10 tips that I give to doctors, but I think it's really important to give them to you as well. Make sure that your physician is making a thorough and as accurate a diagnosis as possible. So when they want to start a medicine, ask them, why are we starting this? What are your goals? What do we expect this medicine to do? So you have a good idea about that. And use the medicine as part of the big picture. So make sure that they're also, like, if you're treating sleep, you want to make sure that you're also doing behavior changes to help the child learn to sleep. Because a child who wakes up in the middle of the night and needs to be put in a stroller to fall asleep every time, they're never going to sleep through the night until they learn to fall asleep not being rolled in the stroller, because that's how they associate falling asleep. So, so you can't just use medicines alone to solve problems. You have to think about the behaviors also. And then always weigh the risks and benefits. So kids with PMS have poor motility, so a lot of medicines can cause constipation. And so always think about that and ask, is this medicine going to cause constipation? Because you want to be prepared. And then, of course, make sure that you agree, and also make sure that what they're prescribing, ask about, will my child take this? Is it, so like some of the seizure medicines I prescribe, they taste horrible. And so I need to know that the family knows this, so that they can tell me right away if their kid isn't taking the medicine. I don't want them to wait 3 weeks until the follow-up visit. And so you just make sure that you're asking questions about that and that the child is going to be willing to take the medicine. And then always, always, always start one medicine at a time, because if you have side effects from the medicine and you've started 2 medicines, you don't know which one is causing the change. And then start low and go slow. So if, I don't know, this is very, very overgeneralized, but you take the smallest pill and you cut it in half. And often that's where I'll start with a medicine. And I'm not talking about treating seizures, but I'm talking about medicines for behaviors. But you want to make sure that the child doesn't have a reaction. And then monitor it carefully, make sure that everyone's on board, that the school might know so they can help monitor, and consider in context of where the child is, biopsychosocial, developmental. And then, once again, kids with PMS don't always respond to medicines the same. as neurotypical children do, or even kids with autism. And so it makes it difficult to just have a set guideline or algorithm, because it doesn't always work what you think might work. Okay, how to manage your medical provider. Because you have to. So the first thing is, when you're starting a medicine, ask what to do if you have a behavior reaction. Can I stop the medicine right away? Because chances are I always tell people to start things on the weekend, because I want the parents to observe first what's happening. And if you do it when the kid's at school, then you're not really going to see. You might get a report. It just depends on how good the teachers are. And so you're at home and it's the weekend, and if you call the on-call doctor, they don't know what's going on. So talk to your doctor before, like, can I just stop it? Or, because often you can, but there's some medicines that they might have feelings about it. So ask them first, because if you stop medicines after, without telling the doctor, some people get very touchy. And try to partner with your provider, but if they can't partner with you and they get very kind of dictatorial, then it's time to find someone else. And it might not be a doctor, it might not be a physician, it might be a nurse practitioner that you find, but somebody who listens to you is really, really important. And then I would say, keep a list of the medicines you've tried for behaviors, or even all the medicines, and just write, like, you tried it, what happened, and when you tried it. Because sometimes when you try a medicine, say for hyperactivity at the age of 5, it may not work well, but it might work well when the kid's 10. And so, because our brains change as we get older, so if I see that list, I can talk about it more. It's easier for me to explain why a medicine might not have worked and why we might want to try something again, or why we absolutely don't want to try that medicine again because of what you learned 10 years earlier with a behavior. But if it's all written down, then it's so much easier for the doctor, because a lot of us aren't very good. I try to keep a list of all the medicines and what's happened, but a lot of people either don't remember or just don't do it. And so it's very helpful if you do. And then I mentioned this before, keep short videos of the behavior that you're seeing. And Tazy mentioned this also. It's really, really helpful for me when a child maybe is having a seizure or is having an unusual behavior, if I can look at it, because then I might be able to either say, oh yeah, this is really different, and a picture is 1,000 words, and once you see it, it's more easy to assess than just having someone explain something. Oh yeah, and I wrote again, reactions to medicine might not be typical. So you guys are the experts, but you can't tell that to the doctors. But you are, because you know your child. But you can say to them, I know I've learned that my child doesn't react to medicines the same way as a typical child with autism, and we know that the mutation causes changes in the brain that aren't always like autism, so kids don't react. And that's not telling the doctor you know more than they do, it's just telling them facts. And usually that works well, and it's received better. You might have other hints also. Can I have the next slide? Oh yeah, this is on the PMS website, and you've probably all seen it. But I even find it useful sometimes when I'm seeing someone, if there's a new behavior, I just go through the little diagram. Did I think of everything? Is there something that I should be thinking about still that I haven't? And so bring that to your doctors if you haven't, because often they want to do the right, we want to do the right thing, but often people are so busy they don't always have capacity to spend the time going to the website. So if you just bring them on a piece of paper, something like this, they might be appreciative. So, so regression in PMS causes loss of skills. We know that behavior changes can also be the sign of an underlying medical illness or psychiatric illness. And remember to advocate. So, thank you. That was it.
Thank you so much for that. I see this is a very popular topic as we have a full house. Thank you for coming in, and for those that had to stand, apologies that we didn't have enough seating. We're going to take some time now to do question and answer with Dr. Neumeyer, and we're pulling up our polling software now. If you guys have been in the other room, you're probably familiar with how we are doing this, but there will be a QR code here on the screen in just a moment, or you can visit the URL, which is pollev.com/PMSF2. Great. So if you guys want to submit your questions in there, and then you guys can vote for ones that you want answered. We try to answer some of the more popular ones so that we're, answering what's on everybody's mind. We ask that you keep it a little bit more general and not too specific about just, your certain individual. I know Anne had mentioned that she would be available maybe for a few minutes at the end if you have very specific questions. So I'll give that a moment here as maybe questions flow in. Feel free to raise your
answer them.
Yes. Feel free to raise your hand too if you're having trouble with the polling software, and we can help with that. All right, maybe we'll start with this first. Ooh, looks like a couple are coming in here. Let's see. All right, we'll start with the top one I can see here. How do I know when to start my child on meds if they have mild OCD tendencies?
So that's a really good question. And I guess what I would say is, we all have some OCD tendencies because they're reassuring. They feel good, they help keep things in order. So if they're mild and they're not disturbing, how you do things, then that's okay. But when they get more severe and they're interfering with normal behaviors or learning or, like taking an hour to get ready for school instead of 20 minutes, then that's when we want to start thinking about it. And then you want to think, well, what is driving the OCD behavior? Is it anxiety? Is it, some underlying medical issue or pain, or is the child not sleeping properly? So then we have to try to figure out what is going on, or is the child depressed? Has there been something in the past in the child's life that has changed a lot and that's driving it? Or is the OCD behavior more avoidance-based? Like maybe they don't want to go to school, so they're doing other things to avoid it. And then why don't they want to suddenly go to school? So what's going on? So, long answer for short question. Next question.
Yes, I think maybe just a little bit of a follow-up because that seems to be popular in the questions here about OCD reoccurrences. Is there a specific thing where you think it's time to reach out to a provider? Is there a certain, step where you're, for sure that you want to have medical intervention, or is it sort of case by case?
So I guess what I think is when the behavior is starting to impair the child or the family's quality of life, like they're not happy. You can just see that something is different and they're not happy about the behavior has become overwhelming for them. Then you want to contact the medical provider and talk to them. But if it's something mild and it doesn't seem to be really impairing, then sometimes behavior techniques can be helpful in managing the mild OCDs.
All right, thank you for that. Switching directions a little bit. After an infection or regression, is there a way to calm the nervous system that you would recommend?
I wish I knew what that was. So we sometimes see, especially in adolescents, a tendency to have regressions intermittently. There's some kids, we don't understand why, whether it's kind of a reaction to inflammation or an infection, and we don't understand that. So there are some kids who've been put on IVIG, which is immunoglobulin, intravenous immunoglobulin, and that helps them, but we don't understand why. And when most of these kids have very thorough workups to try to understand whether they have like an inflammatory condition of their brain or an encephalitis, we don't find anything. So we don't understand it yet, but that it may somehow relate to impaired neural transmission, because lots of things can impair neural transmission, not just SHANK3, but also infections and other things.
Great. Is thermoregulation still considered prevalent in PMS? I think referring to regulating body temperature.
Oh, yeah. That for some kids, that's a real problem.
Do we need to be concerned about regression at the age of around 7 or 8, or is that to be expected? So whenever a child regresses, I take it very seriously. And so we'll look into reasons and try to figure out if there's a reason for regression. And sometimes we can't find one, but it's still a reason to be very concerned. But sometimes we can't find a reason for it. Yes. So this is a question I know that I see a lot in the family group, and it comes into us quite a bit. But do you have any guidelines or recommendations to teach your child how to use the bathroom by themselves? At what age should we start trying to teach them? So there are many things about toilet training that are a challenge.
So if we're talking about toilet training for urine, sometimes that's easier because you can just, on a schedule, put the kid on the toilet. But for stool, it's harder. So then, and I'm not a gastroenterologist, so I'm not the best person, but I do know that if the child is always used to standing in a certain corner to have their bowel movement, they're not going to do it sitting on the toilet in a different room. So you want to make small changes, like maybe have them only stand in the bathroom to have their bowel movement. So at least you're starting to make a small behavior change to get them used to eventually having a bowel movement in the bathroom. But it's, I don't have an easy answer for that one, because it usually involves a lot of changes, and often the kids are very constipated, so you might have to resolve the constipation first. And a lot of children withhold because they don't want to go to the bathroom in a new place, and so that exacerbates the constipation. Yeah.
We're getting so many great questions, so I'm going to keep going here. We saved a little extra time because we knew this would be popular, so thank you for answering these for us. Excessive chewing seems to be common. Clothing, plastic, etc. Any insight into that?
So I don't know why, but I think that chewing is a very satisfying behavior. It's self-soothing. I mean, a lot of people eat to self-soothe, and I think the chewing is also soothing. Sometimes if it comes suddenly out of the blue, then I worry that there's some dental problem, a swallowing problem. Like if you look at kindergartners, just typical kids, you'll notice a lot of them have wet shirts because they're teething and they're chewing a lot. So typical kids do it also, but they usually just stop. But I don't know how to solve that problem, and of course we see so many kids here with chewy toys because it's soothing, and it may also help with swallowing.
Sometimes my child, when she is having an issue, can get violent when you try to correct them. What's the best course of action? Typically, she's very sweet.
So I wish I had my ABA colleague here with me, because she would say you don't want to reinforce the behavior, and sometimes even giving attention can reinforce a behavior, but and sometimes allowing the child not to do, well, often, if the child has a tantrum when they're, I don't know, asked to wash their hands and they don't end up washing their hands, then they know the tantrum works well. Or, you know, the toddler in the supermarket who has a tantrum and then is given a piece of candy to quiet them down. They have just learned very effectively how to get a piece of candy in the supermarket. So you have to look at what you're doing to potentially help the behavior or maintain the behavior. And similarly, sometimes just turning around and walking away from the child when they're getting aggressive can be a very effective way of not giving attention for a behavior. Of course, you have to make sure that everything's safe. So sometimes partnering with a good behavior therapist can be helpful when things like that are happening.
This one is a little bit along the same lines, and it is specific, but I do see like a theme here that we've received, questions about. So it says, my daughter is great in public settings, but when having family over to the house, she gets very, very upset. But seeing people outside the home, she's perfectly fine. Is there a specific reason in which, we would see this? I would have figured it would be the opposite reaction. Thank you.
So that might have to do with kind of changes in routine. It's like she knows her house is for her family, and then other people are coming into the house, and those people don't live in the house, and it might be upsetting. So sometimes a social story can be helpful, taking pictures of the people, or even having pictures in the house and talk about that they're coming, and they're going to have dinner, and then they're going to leave and go home, and then the house will be yours. Sometimes just doing something like that can be helpful for the child, or having a picture schedule to show them, and when the person comes, you bring the child over and you show them on the schedule so they understand that that person's going to come and then they're going to leave. So sometimes that can be helpful.
You talked a little bit about ABA already, and this is a specific question for that. Do you think ABA therapy would be beneficial in young adults, say 21 plus?
So Massachusetts has just approved ABA coverage for adults, and it can be very helpful for adults, especially, they're at 22 in Massachusetts. That's when children who can move into a group home, if they haven't been in one for residential schools, or they're in a residential school and then they move to a group home. So there are all sorts of changes that have happened. And ABA can be very helpful for helping the child adjust to the new group home. So, or with, relearning certain behaviors which were lost, or certain skills which were lost because of a major change like moving group homes.
This is a specific question about the Lurie Center. Is the PMS clinic still occurring there?
Yep, children and adults.
Great. This is a specific question on medication, and I won't be able to probably pronounce one of the two, but is Abilify and then Risperidone. Am I saying it correctly?
Yeah, Abilify is aripiprazole, and risperidone, or Risperdal. Yeah.
Is that safe to stop immediately? Are they safe?
So if they're just started, you've been on it for 2 days, you can stop it safely. But if you've been on it for a long period of time, you can have a reaction just from stopping it. So typically, a psychiatrist will taper it down pretty slowly so that you don't have a reaction. Because the medications change your dopamine levels, and the body has to get used to the medicine starting. So if you started at a really high dose, for example, you might have a reaction. And similarly, if you're on a higher dose and you just suddenly stop it, then it's almost like a withdrawal. It's not like, I don't know, an addiction withdrawal, but your body needs to adjust to gradually lowering of doses.
I think I have about 1 or 2 more questions here, so if there's any final questions, be sure to submit them. This one I'm gonna probably not nail the name either, a medical term here, but how common is fecophilia in PMS, and any suggestions for treatment?
So I don't know how common it is. So fecophilia is eating of stool. And I think that, I've seen it, it happens, and kids just are exploring everything, and to them, stool is just like anything else. I don't think it's gross the way most of us do. And so they eat it. And it can be a sign of, like GI distress, but it can also just be more exploration and not understanding that it's not sanitary to play with stool.
So we have 2 more here that I would love to ask, and then I think we will probably wrap it up. Do you think weighted vests or blankets help with anxiety or OCD behavior?
I would say they can be very helpful, and so it's worth trying, but for some kids, they don't seem to work at all. So there's some organizations that will loan you a weighted blanket or a weighted vest to see, because it's painful to have to go out and buy one and then discover it really doesn't work. So that's what I would say. And sometimes, these spandex vests can also be very reassuring for kids. They're like really tight in the same way, the socks are that, yeah.
Thank you. Okay, we're going to end with this question. Is pandas common in PMS?
So PANS or PANDAS is pediatric autoimmune neurological disorder associated with strep, a strep infection. And some children with a strep infection, they get OCD behaviors or that are just related to having the strep, and once you treat it, it goes away. So this is an example of an autoimmune phenomenon that occurs with an infection. I have never seen it in PMS. But do autoimmune phenomena occur with PMS? Probably they do. I just haven't seen it. And you raised your hand, so maybe your son had it. Yeah. So, and it's pretty obvious sometimes that kids get an infection, or, it's around the school and suddenly there's a big behavior change and somebody thinks to check a strep screen and then it's positive and then you can treat it, and often that solves the problem, but not always.
So we're going to wrap it up there with questions. If you would all join me in thanking Dr. Neumeyer for being here with us.
Thank you all.